All right, let's talk about diagnostic tests and how we monitor neuro patients in the ICU. One of the oldest tests that we have, imaging-wise, is the CT scan. And so remember that CT, or computed tomography, is a fancy X-ray. So it uses X-ray energy to penetrate the skull and show us mostly bony structures, right? Calcification is the thing that shows up best on CT scan and regular old X-rays. We can also add contrast to show tumors, vasculature, bleeding, things like that. And you can see a couple of contrast enhanced areas here showing up on this CT scan. Now, the way you differentiate a CT scan from an MRI of the brain is you look at the outside. Remember that bony structures are much better represented on a CT scan because it's an X-ray, and MRI tends to be better for soft tissue like brain matter. So when we look at this CAT scan, I can tell this is a CAT scan because of how bright this skull is on the outside here, and it's well visualized. Now, contrast that with this little teeny tiny ring around the outside that is on this MRI scan. So here is the skull that I'm pointing to, but what I really see best is the soft tissue inside. Now, with MRI, we have different ways of processing the images. Essentially what this does, the MRI, or the nuclear magnetic resonance imaging, it takes all of the atoms and lines them up in such a way that the differences in densities show up. Now we can change the way, and by the way, when those different densities show up, they're represented on the MRI image as black, white, or gray. And so those different densities then contrast with one another so we can see different structures. Now, the MRI that you see here, or the images that you see here, are actually different processes. So one, this is what we call a T2 weighted image, and that just has to do with the processing of the image that shows us different kinds of things. I'm not an expert at this, so I can't tell you exactly when we use T2 or T1 or what have you. Just know that there are different weights that are used. And in this case, we can see the T2 image looks different from the T1 image. So the T1 image is better for this brain matter here. T2 images seem to show higher contrast between these, but whatever. Now, the other thing that we can use is gadolinium. So gadolinium, if you look it up on the periodic table, is actually an element, and it can be dissolved in a liquid, maybe not dissolved, that might not be the right word, but we can put it into a liquid form that can be injected into the body. So it's literally metal that is injected into the body and contrasts with all the other tissue, and so we can see vascular structures with it. So this is the this gadolinium stuff is the contrast that we use with MRI. Now, contrary to what contrast is with CT scan, which, by the way, is nephrotoxic, right? It can damage the kidneys. Gadolinium doesn't do that. It does not pose a risk to the kidneys. There is some evidence, however, that maybe it sticks around in the brain a lot longer than we would like it to, and the jury is still out about whether that's causes any harm later in the future. But it might not be entirely benign as we once thought it was. Another commonly used test is an angiogram. So an angiogram actually gives us much finer detail about what's going on in the brain. We use this to visualize the vascular structures in particular. And so here you can see actually a giant lesion here, vascular lesion. I'm no brain imaging expert, but this appears to be a aneurysm in the middle cerebral artery somewhere. So that technique is done in a cath lab kind of setting where they go in through the femoral artery usually, and they put the catheters up through the carotids and right up into the vasculature in the head. And of course there is some risk involved in that, because whenever you're monkeying around with vessels in that vicinity, it can cause mischief, such as dissection of the vessel or something like that. Now, the other technique that they use here, because you probably are thinking, when you inject dye, I've seen that be white. Well, they do this thing called digital subtraction angiography, or DSA, where they just put up the opposite images. It's kind of like the negative. And so that negative gets shown here. And those images now are reversed. So any vessels that are that have dye in them show up as black instead of white. The other way that we can do visualization of the arteries in the brain is with CT or magnetic resonance technology. So if we inject dye and do a CT scan, that gives us what we call a CTA, or CT angiography. Or if we put the gadolinium in, then that's the MRA, or magnetic resonance angiography. But nothing's quite as good as actually putting dye in to the into the vessel and directly visualizing it with the angiography. EEG is another commonly done test. It's one of the older tests that we use to examine brain function. And what we do is we hook up a million different leads to the head in all sorts of places that I don't even know how they do it. I know how to do a 12 lead, but I don't know how they put all this stuff on. And so there's a wire mesh that comes off of the patient's head, and they're hooked up to this machine. During the testing, they're usually video monitored as well to see what their wakefulness is. And then the neurologist uses that to uses all that information together to figure out what the brain function is. So we can see, we can localize seizure activity with this. We can tell someone's wakefulness and arousability. All sorts of other things like that are useful. Lumbar puncture is commonly done, and we use this for diagnosing CNS infections, among other things. The important parts of doing this procedure are seeing what the opening pressure is. So if we put the needle in and we see an opening pressure that's over 200 millimeters, that's a concern, right? We also look at the color. It should be sort of a pale yellowish but clear. Should not have any cloudiness to it at all. There should be a couple of white cells in it here and there, and there should not be blood in it. But in fact, when you first put the needle in and look at the first couple drops, you put those first couple drops into a separate bottle, because there will be some blood in those. And then the blood should clear on the second and the third little bottle that they're taking the specimen from. So the first bottle usually has some blood in it just from the stick. Second bottle may have a couple of remnant red cells left. But by the third bottle, and these bottles are tiny. I mean, it's like just a couple of drops in each. Then you should have no blood by the third one. Then we measure the amount of protein and glucose, and that gives us information about the stuff that we're seeing in there as well. One thing that we see with meningitis is response to these two signs, Koenig's sign and Brudzinski's sign. Koenig's sign is when you when you flex the hip and then extend the knee or extend the lower leg at the knee. That causes pain in the back of the neck, as you can see here. And then Brudzinski's sign is when you flex your legs and lift up your head. That causes intense pain as well. These are the meningeal signs, and these are pathognomonic of meningitis. So those are some of the common tests that we do. Let's talk about intracranial pressure monitoring that you as the nurse are going to be doing. So first of all, the pathology of increased ICP is this. Remember that the brain is in a box, and that box includes the brain, the blood, and the CSF, and anytime that any of those is elevated, it's going to increase the pressure in the cranial vault. So when we have that increased pressure, then there's also a decrease in cerebral blood flow, and that can affect things like the PaO2, the CO2, the pH changes, vasodilation occurs, and it's a vicious cycle. So the causes of increased ICP can be cerebral edema, right? Whenever you damage something in the body, the inflammatory response happens, and part of that inflammatory response is increased blood flow to the area. Another part is some leaking of fluid from the cells and from the vasculature, and that interstitial edema happens, and that is the cerebral edema that we see with increased ICP. That can be a little bit for a tiny insult or a lot for a major head injury. So the kind of things that cause cerebral edema are listed here. Increase in cerebral blood flow can result from hypoxemia, hypercapnia, responses to fever, shivering, seizures, physical activity, etc. And then obstruction of venous flow, right? So anything that goes in has to come out. And if you increase the venous resistance, then there will be greater resistance to cerebral blood flow. And then finally, an increase in CSF can also increase the ICP, and we see that happen in infection or in certain blockages too. So these are all the reasons that we can see increase in ICP. What are the symptoms of ICP? Well, the early symptoms are restlessness, anxiousness. Patients may have visual disturbances, persistent headache. As it goes later, as the symptoms progress, then we get to a change in consciousness. They may be unarousable. Their pupils may change. There may be posturing. Projectile vomiting is also common. We talk about projectile vomiting as if it's like not a special thing. We just say if somebody's vomiting and it's, and they're really vomiting a lot, that's projectile vomiting. But projectile vomiting is its own thing. Projectile vomiting is due to increased ICP, and it is impressive. I mean, it is literally very powerful vomiting that you've not seen before. All right. Cushing's triad, by the way, increased systolic blood pressure, decreased pulse, and a widening pulse pressure are the late signs of increased ICP. What do we do for patients with increased ICP? Head of the bed up to decrease the pressure. Keep the head midline so they shouldn't be off to the side or anything. Try to keep everything in line. Avoid extreme hip flexion and Valsalva maneuvers that can cause intracranial pressure increases. We want to make sure that patients are cooled adequately if they're hyperthermic. All the things that are listed here. I'm not going to read them all to you, obviously. So what are you going to do if your patient's ICP is elevated? Well, you're going to first note it. You're going to see that the ICP is above 20. And within 5 minutes, the physician has to, if it persists for more than 5 minutes, then you have to notify the provider. Remove all the stimuli that you can, quiet the room. Make sure that the head is in a neutral position. Continue to assess the patient and see what's what, and then we may need some orders from the provider to address the problem. Medical treatment for increased ICP is aimed at obviously reducing it. So maintaining the cerebral perfusion pressure is key. We may need to pull off some CSF in order to equalize the pressure, not equalize it, but improve the pressure and maintain the CPP. We may need paralytics to decrease the metabolic demands, like shivering, coughing, things like that can increase the ICP. So when we paralyze patients, of course, we have to sedate them first. Don't forget that. And then we have to address cerebral edema. So steroids and then diuretics like mannitol, for instance. Sometimes hyperventilation, but that's really fallen out of favor. And if you think about what happens with hyperventilation, we're blowing off CO2, and that changes the acid-base balance, which in turn decreases the intracranial pressure. But it turns out patients don't do as well when they are hyperventilated, and so that practice has really fallen out of favor. If you wanted to do that, you should have practiced when I started, because we did that a lot back then. Finally, the other reason, in addition to the cerebral perfusion pressure, the other reason that we're so concerned about intracranial pressure is the potential for herniation. And herniation is where the brain parenchyma actually goes through another layer of the brain. So for instance, the tentorium here is what separates the midbrain and the more primitive brain functions from the higher processing things like, in the cerebrum, the ability to think, essentially. When you say that somebody has a supratentorial lesion, we're talking about something in the cerebrum itself. But if the pressures become too high here, and then, for instance, you don't treat it, or you maybe put a needle into the spinal canal, you can actually cause such a rapid, severe pressure change that this tissue herniates through the tentorium, for instance. So this is an irreversible catastrophic event that will lead to the patient's immediate. It essentially causes brain death instantly. So this is something that we try to avoid at all costs. When we get into ICP monitoring specifically, here's the way we do it. We first of all institute ICP monitoring for anybody who has a Glasgow Coma scale between 3 and 8. Remember, 3 is the very lowest number that you can get. 8 is comatose. Anything below 8 is comatose. So we assess their ICP and how it changes in response to therapy. We do this for intracranial hemorrhages and subarachnoid hemorrhages, congenital anomalies, meningitis, etc. There are different ways that we can monitor it. One, we can use a bolt, and we just put a bolt through the skull and it sits right here, and we measure the pressures there. We can use a subdural catheter. I haven't seen this very often. An epidural transducer, which just sits very high and doesn't go inside the pia mater. And then there's the intraparenchymal, or I should say the dura mater. Sorry, not the pia. The dura mater is the outside one. We do have the potential to use the intraparenchymal fiber optic catheters that go directly into the brain. And then there's ventriculostomies, and we're pretty accustomed to doing that. The nice thing about putting something into the ventricle itself is that we can not only monitor there, but we can also pull things out. So we can pull out excess CSF fluid to help treat the pressure. So this is an example of a bolt that's been put in. So remember, the bolt just goes right through the skull and monitors pressure here. We have a little catheter in that. and that pressure then becomes transduced on the monitor. But if we put the catheter into the ventricles or into the lumbar space, then we can actually monitor the intracranial pressure, and we can drain off CSF when we need to. And here's examples of that. So we can see the CSF is being drained off here, and obviously this is a intracerebral hemorrhage of some sort that's caused blood to collect here. Pressure is monitored, and CSF is drained off as need be. So while your patient has these devices, you want to make sure that we're maintaining the cerebral perfusion pressure, and we're monitoring the CSF output so that we can see the cell count, protein, glucose, and cultures, etc. So the EVD, essentially, when we zero the EVD, we need to do it in line with the level of the tragus. Remember, the tragus is that little thing on your ear there. And so that's what we use as the centering point. Remember, when we do a Swan-Ganz catheter, we use the right atrium or the phlebistatic axis as the zeroing point. Here we use the tragus. These are different ICP waveforms. I'm no expert at this, but you can see that the P1 waveform should be the biggest, and then the P2, and then the P3 is the smallest and almost imperceptible here. But with significant elevation in the ICP, the P2 actually becomes higher. And so in a compliant brain, again, the P1 is the highest. In a non-compliant brain, the P2 is the highest. When we have somebody with intracranial pressure monitoring, we monitor them hourly with vital signs and mean pressure and cerebral perfusion pressure and ICP. We monitor their level of consciousness and pupils and all the other things listed here. The dressing has to be changed at least every 72 hours or in accordance with your unit's policy and procedure. And for transport, we always clamp that drain, and also when we're repositioning the patient. There's another device called a lumbar drain. Now, we don't use this to measure ICP, and we don't zero it or do anything like that, but we do use it for pulling off extra CSF fluid, particularly for shunt malfunction. So if you have a shunt that's in place, a VP shunt or a VA shunt, VP stands for ventriculoperitoneal, means that that drain goes from the intracranial ventricle down through the neck, down into the chest, and down and empties into the peritoneal cavity. Excuse me. Or a VA shunt, which is much less common, but that goes from the ventricle in the brain into the right atrium. So these devices are temporary, obviously, and used just while we get the patient through the shunt malfunction, typically. And the placement is done like this. They go into the lower back here, and it goes between L2 and L3, and they put the lumbar drain in that method, and that can just be done at the bedside. The complications of extraventricular drains or lumbar drains is the potential to overdrain CSF, right? And if you overdrain CSF, obviously the cerebral perfusion pressure will be fine, but your patient's going to have a wicked headache and potential for infection. And then meningitis can also happen because you have a foreign body that's going in through all these structures, and anytime you have a foreign body, that introduces the potential for infection.